And it's my honor and pleasure to introduce Professor Renato Fanchin. I should spend a lot of time to read the CV by Renato, but I think that what is very important to mention is his current research interest in the assessment of ovarian follicular status, ovarian aging, controlled ovarian stimulation. Renato, I remember, I want to tell you something personal. He seems to be younger than me, but I was especially in the specialty school. I started reading his papers, so he inspired me at the beginning of the history, and the contribution he gave in innovative approaches in IVF and in control, always original, always a different angle. He was one of the first to study MH and to propose MH in our community, and it's my pleasure to give you the podium, because the topic, new insight in the follicular genesis, in the ovarian function, I think that the pre-treatment of androgens of poor responders is one of the most relevant curiosities we have at the moment.
Thank you, Carlo, for this nice introduction that I don't deserve. But it's a pleasure. It's a real pleasure to me to be back in Italy many years already, and this is thanks to my friend Antonio and Livio, of course. This invitation was very, very, very nice. Thank you very much. Should work. Next slide. I have nothing to disclose except for the gift that Antonio promised to me for coming here to Modena, but I don't think this is very important, so I am not mentioning that, okay? The management of ovarian function defects is, I think, it is the core of our jobs today. We have these patients that come to our clinics and they have many features, but I would like to focus on mainly the reduction in the number of follicles that they always have, and this inadequate response to FSH, that some of them will have too. Many approaches have been proposed during years for managing these patients, but none of them was effective until now. And so the task that I have today is even more difficult. But maybe we thought about getting interested to earlier stages of folliculogenesis firsthand, as we discussed this morning. So if we treat patients during the menstrual cycle, maybe it's too late. So it would be maybe opportune to get interested in the follicles during the basal growth phase, and this is where the androgen hypothesis is based. So what is the androgynous hypothesis? Where is it based? In clinical features, of course, we all observe patients with PCOS that have an excess of follicles in growth. Some cases, particular cases of hyper androgen production as congenital adrenal hyperplasia or androgen producing tumors, and these women will have an excess in folliculogenesis or hyperfolliculogenesis. And the last model is the female-to-male transgender patients who will acquire progressively PCOS phenotype. So this was a histological piece from our program in the Foch Hospital, and this was a female-to-male transgender patient, so there's a very similar aspect to PCOS. So we think that androgens are boosters of folliculogenesis, and the receptors is more expressed in not in mature follicles, but in immature follicles, as shown by Stephen Hillier. So they are fourfold as high in immature follicles. So the target of androgens may be the follicles on growing phase. And when you talk about androgen hypothesis, the first paper that comes to my mind is this very elegant paper of Vendela in 1998 already in GCI, so a very good paper in rhesus monkeys, where we treated these animals with virilizing doses of androgens, and we got progressive, very quickly changes in folliculogenesis. Over 10 days, we got as many follicles as you can see in this picture. So it's a dramatic effect of androgens in folliculogenesis in these monkeys. And we observed in these cases that folliculogenesis was augmented on all follicle sizes. And when we look at cell proliferation, we had more proliferation of granulosa cells in patients treated with testosterone, this animal, sorry, and less apoptosis. So more proliferation, less apoptosis for follicles in patients, in these monkeys receiving androgens. And also very importantly, in these cases, androgens seem to promote even an increase in the number of primary follicles, indicating that the recruitment of follicles will be increased in these monkeys. So we are doing something to the folliculogenesis when you administer androgens in very high doses, of course. And when, again, another team look at the mRNA of androgen receptors, and with the Ki67 approach, we had a relationship of cell proliferation related to the androgen receptor expression and less apoptosis. So more proliferation, less apoptosis again. And I think this is the center of of my presentation. This slide is the staining of FSH receptors in the granulosa cells that is increased progressively during treatment by testosterone. So there is a progressively sensitization to FSH by testosterone treatment in the rhesus monkeys. Again, we show here a correlation between the number of follicles in PCOS patients and the degree of hyperandrogenemia. So more androgens, more follicles, and more ovulatory disorders, of course, in these cases. So we are tempted to go to a therapeutic phase and maybe treat our patients who have less follicles with androgens. So there is a threefold approaches. Even we can administer systemic androgen treatments, or provide, improve the production of androgens by the TICA cells, by LH activity, or even blocking the conversion of androgens in estrogens by inhibiting the aromatase activity. So we're going to very quickly review the papers on the main papers on these approaches. The first was the use of a pro-androgen called the DHEA. You are familiar with that. And this paper in 2000 by Casson was the first one who showed in 6 poor responders, patients, a dose of 80 milligrams per day. So the usual dose is 75 today, but they use 80 milligrams per day for 2 months. And the relationship between estradiol, peak estradiol levels and the number of ampules that we used during stimulation was improved when patients received DHEA. So there was a sensitization of follicles by this treatment. Again, the Norbert Gleicher team, Barad and all, in 2006, showed again that in poor responders, DHEA 75 milligrams for 4 months could improve the response to stimulation. This is the number of oocytes, 3 against 1.4, and the number of day 3 embryos was higher too. So there was a positive effect in their hands. Of course, it was not a prospective randomized study, and this is the problem of all these studies about androgens. We don't have a very solid information about the effectiveness. Again, here, a paper from China, look at the profile of patients, so FSH 100, so menopausal range, and they treated these patients for 16 weeks, and in their hands, patients treated had more growing follicles at the end and an increase in ovarian volume. So another option instead of DHA is giving directly testosterone. Here we have testosterone patches, so the dose is 2.5 milligrams per day for 5 days, and this is one Balash paper. So cycle 1, cycle 2 without testosterone, these poor responders behave badly, so 1.6 follicles in cycle 1 and cycle 2. And when they pre-treated these patients with testosterone, the number of follicles increased to 8. So it was a dramatic effect, but was not confirmed by CYP in a later study using the same methodology where they didn't find any effect. So there is all over the presentation, I'm gonna show you conflicting results on that. Now testosterone gel, it's an option too, easy to use, 10 milligrams per day, so 15 to 20 days. This is when Nathalie Massin, when she was with Joanne Noël Hugues in France, they used that. So they increased the testosterone levels of patients, of course, but they didn't get any positive result on neither IMH, neither antral follicle count, in this patient, again, placebo. Another study with testosterone gel, it was this one for China, so more patients, but not randomized, not again placebo, no blind in this study, and they had results, very interesting results, with an increase in the number of oocytes. Where are here we have a slight, the number of oocytes were the same, but they have more pregnancy rates, so live birth rate, and less miscarriage, the same miscarriage, but more on live birth rate. Less, showing that the effect should be via the quality of the oocyte. Anyway, last option of providing our ovaries with androgens is inhibiting the aromatase. So it was here the paper by Mituali from Bob Casper from Toronto, and very interesting. They were the first to propose that. So using aromatase inhibitors for improving the FSH response. So they combined FSH only with the FSH plus aromatase inhibitor, and they had more mature follicles at the end of stimulation after this approach. But this was not corroborated by a later study by Bill Schoolcraft from Colorado, and Bill didn't show any difference between letrozole treatment using the microflare protocol. So microflare protocol or microflare plus letrozole, we didn't show any difference in the IVF outcome, neither the oocyte retrieved, neither implantation rate, sorry. So the third approach is providing LH activity, and I'm quoting this patient by Isabelle Cédrin from France too. They used recombinant LH 300 IU per day for 7 days before starting FSH, recombinant FSH treatment. And in their hands, they did not succeed with this dose of LH to increase circulating testosterone levels, but obtained more embryos in the patients having been pre-treated by recombinant LH. So have here 7, again 5.5, so it's in the limit of significance. So they have the same number of eggs, so 9.2 and 10.8. So we cannot conclude about a real effectiveness of this LH activity priming. Another study decided to combine aromatase inhibition with LH activity by ACG administration as a priming for stimulation, and in this study, results were pretty the same in patients receiving androgen priming by ACG and aromatase inhibition as compared to controls. So we have here, I'm going to have number of oocytes the same, and the outcome of IVF the same too. Another paper that should be quoted is the bolus of ACG before starting FSH. And this, in this group, they obtained amazing results with an increase in embryo quality and an increase, a significant increase in pregnancy rates in these patients, but not translated by the number of difference in number of sites. Again, another paper from Brazil, they used the same bolus and obtained more top quality embryos in ACG patients as compared to controls. Implantations are better too, but a small number of cases, so we cannot really conclude about the effectiveness of any of these approaches. So when we don't have enough data, we go to meta-analysis. I don't know if it's a solution or it's adding up to the problem, but we conclude that for DHEA, the most of studies don't show any improvement of clinical pregnancy rates in patients receiving DHEA. Of course, there is the heterogeneity and the quality of the studies. And for testosterone administration, we have maybe a difference, but it's a very, very small confidence index of this meta-analysis. So it's not really conclusive to the clinical practice. To maybe finish this presentation, would like to know about another concept that involves androgens. It's called augmented folliculogenesis. And it's meant to treat pool responders. And during a long time, I've been thinking about the solutions for these patients, and maybe I always is doing like this, but I'm trying to reinvent the wheel. So I thought about the early folliculogenesis, and I thought which hormone I would like to give to the follicles during this phase. And I came up with FSH. So I was thinking about using FSH. To target not the recruitable follicles, but to improve the growth of pre-antral follicles. And Elizabeth McGee from the Aaron Shu group has shown that FSH does something to the growth of pre-antral follicles in rats. So we have this stimulation of, we are boosting the follicle growth with FSH administration. And again, in presence of androgens, FSH will improve the growth of the same follicles. So why not wondering about treating patients 2 or 3 months before IVF? Not with anything else, but with FSH. FSH boluses, during the time course need to be, the dose and time course need to be defined, but maybe we can wonder about 5 or 6 days per month, and then doing controlled ovarian stimulation. I was very interested in papers showing that the rebound cycle, after we stop the stimulation, the other cycle, the upcoming cycle, is better, is much better. And I didn't believe that. And I started to observe my own patients. And in patients who had a very reduced antral follicle count, when we go to the stimulation and we cancel the patient, if you invite this patient to come back 2 weeks later or 3 weeks later during menstruation, the number of antral follicles will be often very different, higher. So we may wondering about not only providing these patients with androgen therapy, but providing them with a supplement of FSH, a chronic supplement of FSH before going to the real stimulation. Of course, this is not a panacea. It's a proposal that could be tested, should be tested in prospective studies. But we need, of course, to define how we can do that. Even 10 days or 5 days course of high FSH doses. The adequate association, if you can treat the patient with DHEA, there is a potent androgen, or even testosterone, or maybe LH too. But this is the proposal that I have today. And maybe I would like to conclude that alleviating reproductive implications of ovarian aging constitutes of one single most important challenges in reproductive medicine in the next years, whereas the relationship between the increased androgen availability and the bulk of growing follicles in the ovary is likely, the best way to provide such activity remains to be set. And the administration of FSH boluses in combination with androgens during 2 to 3 preceding cycles in the augmented folliculogenesis concept should be further evaluated. Thank you very much.